Good afternoon, everyone, and a very warm welcome to PSG Med Talks January 2025. We are delighted to have you all here today joining us for an enriching session where we explore cutting-edge developments in the field of general surgery. We are in for an insightful journey delving into key innovations, expert-led discussions, and case studies that will shape the future of surgical practices. Our first session will offer a comprehensive look at the role of lasers in general surgery with a special focus on laser hemorrhoidopexy, presented by Dr. Chitra, consultant in general surgery department. Dr. Chitra will walk us through the advantages and evolving techniques of laser treatments, providing us with a fresh perspective on this exciting field. Next, we will get a glimpse into the transformative journey of treating varicose veins as Dr. Sheikh Asik, assistant professor from the Department of General Surgery, unveils the advancements in diagnosis and therapy for this common yet impactful conditions. Both these sessions will be moderated by Dr. S. Vishnuvardhan, Professor, Consultant from the Department of General and GI Surgery. I welcome you all, sir and ma'am. Following this, we have an engaging case-based panel discussion on a highly relevant topic, diabesity, collaborative solutions. We are honored to have our chief guest, Dr. Santosh Jacob, an expert in orthopedics and sports medicine from PSG Hospital, Chennai, who will share his invaluable insights on his intersection of obesity and diabetes and how collaborative approaches can provide more holistic care. The panel will be moderated by Dr. S. Balmurugan, consultant in bariatric and metabolic surgery, with contributions from our esteemed panelists, Dr. V. Rammurthy, HOD and Professor Physical Medicine Rehabilitation, Dr. M. D. Varun, Associate Professor and Consultant Pulmonology, Dr. Tyagarajan Thangavelu, Senior Consultant Endocrinology and Diabetology, Dr. V. Kavita, Chief Dietitian and Head Department of Diabetics. We hope today's discussion will spark new ideas, foster collaborations, and inspire further advancements in surgical care. We are grateful to have such esteemed experts with us today, and we look forward to their perspective on these critical topics. Thank you all once again for being part of PSG Med Talk January 2025. We hope you enjoy the sessions and take away valuable knowledge from your practice. Let's dive into the first session. I welcome Dr. Chitra.
Good afternoon, professors, seniors, my dear colleagues and students around here. I'm thankful to the Department of Surgery for providing this opportunity to talk about laser hemorrhoidopexy, which is very new to our department, and we are doing few cases of late. So the content of the topics today is, I'm going to talk a little about the definition, history, anatomy, etiology, the grades of hemorrhoids, and symptomatology and treatment, various treatment modalities for hemorrhoids. Hemorrhoids are symptomatic enlargement of internal hemorrhoidal venous plexus. So it's derived from the Greek word hema means blood and rous means flowing. In Latin, pila means ball. So if you look back in history, in Egyptian, Babylonian and Greek resources also, there are references of hemorrhoids. And Hippocrates also mentions about the treatment of hemorrhoids. This is an image which shows hemorrhoidal surgery done in this image is procured from somewhere in 11th century. So a little about the anatomy. So there is surgical canal and the anatomical anal canal. So in between is these two lines. Here is the dentate line as I'm pointing here. The dentate line to the anal verge is called the anatomical anal canal, and from the anorectal ring to the anal verge is called the surgical anal canal. So in between this dentate line and the anorectal ring lies the internal hemorrhoidal plexus as depicted in this image. This is the internal hemorrhoidal plexus from where most of our talks is going to be about this internal hemorrhoids come from. So if you look into the anatomy, the internal hemorrhoidal plexus are mainly formed by tributaries of the superior rectal artery and vein and middle rectal artery and vein. So we, based on where it arises, we can classify it as either internal hemorrhoid or external hemorrhoid. So internal hemorrhoid arises from these internal hemorrhoidal plexus and external is from the external. This is an image of an external hemorrhoid. So based on the location of the hemorrhoid, we can classify it into primary or secondary. The most common three places are right anterior, right posterior and the left lateral hemorrhoids. And whatever appears in between these hemorrhoids are called the secondary hemorrhoids. So based on the proctoscopic examination and the symptomatology, we classify these internal hemorrhoids into various grades. Grade 1 is there is no prolapse, but prominent blood vessels are there. Most of the patients won't be symptomatic in this. Only grade 2, 3, and 4 can be symptomatic. So grade 2 is where there is prolapse of hemorrhoids, but there is spontaneous reduction. Grade 3 is where there is prolapse on bearing down, but it requires manual reduction. Grade 4 is where prolapse with inability to manually reduce it. That is complete prolapse. So etiology, there is various theories for etiology of hemorrhoids, and human erect position, pregnancy, obesity, ascites, and straining during defecation, excessive time spent in the toilet, strenuous activities, all are related to increased intra-abdominal pressure. And one of the theory is the sliding theory, the sliding anal cushion or cushion theory, which postulate that there is abnormal slippage of cushions in the anal canal. Cushions are nothing but these hemorrhoidal, internal hemorrhoidal plexus. I know these images have moved a little. This is normally these part ligaments or Treats muscle is present between the internal hemorrhoidal plexus and the sphincter. Due to excessive straining or like I mentioned, the pregnancy or strenuous activity, there can be stretching of weakness of this ligament and stretching of the or prolapsing of the internal hemorrhoids. So how do patient present is various presentations are, you can present with bright red, painless bleeding, pruritus. Prurite is more common in 3rd or 4th grade of hemorrhoid, or they can present with mucus discharge. And it's ideal in patients who are 50 and above presenting with hemorrhoids. It's ideal to do a colonoscopy to rule out if there is any underlying malignancy. They can present with various complications like strangulation or thrombosis, ulceration, gangrene, or very rarely portal pyemia. So various treatment modalities are based on the different internal hemorrhoidal grading, what we mentioned earlier. So grade 2 and 3, Barron's banding can be applied like shown in this image. Proctoscope is applied and the banding is done. And after 2 weeks, within 2 weeks, the hemorrhoidal plexus slough out. This can be done as an outpatient procedure. And this is usually done in patients who are not very fit for surgery and anesthesia as an outdoor procedure for grade 2 or grade 3 hemorrhoid. Stapler hemorrhoidopexy is wherein the mucosa and submucosa along with the vessels are stapled. This is generally always done under anesthesia, and it is done for grade 3 or 4 hemorrhoids. Open surgery, the good old Milligan-Morgan procedure, or which is open procedure, or closed procedure called the Parkes procedure also can be done grade 4 or 3 hemorrhoids. What we are going to talk today is about the laser hemorrhoidopexy, wherein laser energy is used to devascularize the hemorrhoids. So the vascular theory says that the hemorrhoids is mainly due to overflow of the blood into the hemorrhoidal plexus, and these novel procedures like laser hemorrhoidopexy or hemorrhoidal laser procedure is based on the vascular theory, wherein we do de-arterialization of the hemorrhoids. So the laser energy is placed in the subcutaneous tissue to shrink. Like shown in this image, it is placed in the subcutaneous tissue and it causes shrinkage of the blood vessels and also causes fibrosis and fixation of the hemorrhoids into the bowel wall. So what we commonly use is diode laser, which is of frequency 980 or 1470. And the first image shows wherein for the artery is either identified by digital after proctoscopy under anesthesia. That can be either spinal anesthesia or even regional anesthesia. The artery is identified either by 20 hertz ultrasound guided arterial ablation is done, or you can do digital palpation and and laser energy is applied over the artery above the dentate line. Then the next step will be through along the mucocutaneous junction. Buzz is made and entered inside, and there are 3 different places like shown in this image along the internal hemorrhoidal plexus. Energy is passed first above the dentate line. Here is the dentate line. So above, at the level of the dentate line, a little below the dentate line, the energy is applied. So based on what diode laser we have, if it's 980, the powers to be set is 12 to 15 watts, and each pulse will be there for 1.2 seconds. So usually we apply 60, 70 and 80 joules for each of these, and instantly after applying these laser energy, local cooling applicants are used. We here, after applying laser energy, we use ice cubes which are present, and then after each of the hemorrhoids which laser application is done, cooling has to be applied. So laser hemorrhoidopexy also can be done wherein there is a mucosal prolapse along with the laser procedure for grade 3 and some grade 4 hemorrhoids. It can be done. So main contraindication for this laser procedure is abscess, proctitis or fistula. So the take home message I would like to say is that laser hemorrhoidopexy which is a upcoming procedure, it's very ideal for grade 2 and grade 3 hemorrhoids because it is very minimally invasive, and there is very less pain and tissue preservation is there, and many studies have shown that there is early recovery. Thank you.
Nice presentation, ma'am. You have given a detailed insight into not only the laser but also into the stapler and also banding also. Like you said, laser has lesser incidence of anal stenosis and also bleeding as well as pain in the post-operative period compared to our open conservative type, conventional type of open surgery. Any thoughts to be shared from the audience or questions, queries to ma'am?
Thank you, sir. Like I told in the last slide, the conventional hemorrhoidectomy is open procedure which is done for grade 3 or grade 4 hemorrhoids, and there is tissue loss in that. Like sir told, the complication rates like anal stricture, anal fistula is very high in case of
studies have been published.
Conventional
laser has lesser complications of sphincter injury.
Even stapler hemorrhoidectomy, we should be very careful when we are applying the stapler, especially not to include the vaginal mucosa. There are chances of fistula formation in those cases also, but laser it can be done even as a daycare procedure. So
complication is less in terms of pain, post-op bleeding, sphincter injury, incontinence, everything.
Pain and use of analgesic is very less in laser procedure. We can, but we have, since we have started now, we are still doing under general spinal anesthesia only, sir. We are not yet done in regional anesthesia. Probably we can start.
In future, you can try to do it as a daycare procedure.
Recurrence not very high.
No, so recurrence is very less.
Very less. Only symptomatic hemorrhoids have to be treated. Grade 2 also not. There are few patients without any symptoms with grade 2 and grade 3. Only when they're present with bleeding or pruritus, then only we advise them for the surgery. In certain cases, we can do this, sir, along with mucopexy, not just laser, with the mucopexy. But patients will always complain of that skin tag and mucosal prolapse which will be present in grade 4. They'll not be very happy with, that's what the studies say. Grade 4, they won't be happy with the outcome.
Though the symptoms have improved, there might be
the skin tags and mucosal prolapse will still be present. At just above the dentate line.
Dr. Chitra has beautifully highlighted the various aspect of hemorrhoids, etiological aspect of hemorrhoids. So in that one aspect is a cushion theory. See, cushion theory is accepted as a justification for stapler hemorrhoidectomy. The reason why they say is they did a study in a newborn and all those things. The anal cushions were there at that time. So unlike animals, human being passes motion vertically down. So this has got a traction diverticulum. So the cushions are supposed to be meant for continence. So what happens over a period of time, in the age of 40 and above, you examine most of the people who are symptomatic or asymptomatic, normal, no complaints. You just examine these people's anus with a proctoscopy. They will have grade 1 or grade 2 hemorrhoids. This reason he has attributed is mainly because of traction. That is why this stapler hemorrhoidectomy had a very attraction towards this. But the problem is the technical aspect in which the stapler hemorrhoidectomy done is not followed, understood properly. That is why you have a total transaction, only mucosal transaction. His idea is to take a strip of mucosa and it's like lifting a curtain. Understand? So whatever traction because of mucosa has become loosened and allows these anal cushions to descend down is pulled up. So when you do stapler, and also it cuts off its arterial supply so that the varicosity of the hemorrhoidal plexus will not. This is nothing but a varicosity of the hemorrhoidal plexus because of multiple factors like other factors like she said straining and irregular bowel habits. The maximum advantage with these conservative procedures because of two things. One, as the hemorrhoidectomy procedure was the classical, art of doing hemorrhoidectomy is lost. Understand? So most of the surgery has become simpler because actual art of doing surgery is lost completely. That is one of the reason why you had a anal stricture because people thought completely you core out the anal mucosa completely, there are no hemorrhoids, but they will come with stricture. Understand? That is the reason. If a person knows how to do hemorrhoidectomy, stricture should not be there. So this is one reason why, because people cannot do this surgery properly. So people have innovated how to avoid less and less problem, and then these surgeries are done above the dentate line. Above the dentate, there is no sensation. So there is no question of talking about pain. Pain is there below the dentate line, the anal skin only. So as far as if your surgery is not involving anal skin, you will not have pain. And lasers anyway, it's an ablative technology, can control the bleeding much easier. That is why these procedures became very common and ideal for symptomatic patients like bleeding or third degree hemorrhoids is ideal. Laser, I think it will completely replace the open hemorrhoidectomy because open hemorrhoidectomy most of the people would have forgotten. They will not venture to do it also. I think mucopexy, I don't know what you mean by with hemorrhoids. So the ideal mucopexy is the stapler mucopexy only is ideal. I don't know whether you meant that. Suture. So you plication sutures, yeah. Okay.
Can laser be used in thrombosed hemorrhoids?
No, it's contraindicated in thrombosed hemorrhoids.
Any questions?
Any other questions from audience side? Okay. Thank you.
Thank you, everyone.
Now it's time to welcome the next speaker. So, a glimpse into varicose veins, unveiling the transformation journey by Dr. Sheikh Asik, Assistant Professor from the Department of General Surgery.
Good afternoon, everyone. I'm Dr. Sheikh from Department of General Surgery. I'm here today. I'm going to talk about varicose vein and how we manage in our department and focus more on laser therapy. So the objective for today is recap on anatomy of varicose vein, understand why the lower limbs are commonly affected, identify the symptoms and signs, and discuss risk factors for the varicose vein and evaluate the management option for varicose vein. Also focus on labeler as a treatment option. So when there's so much else to talk in our department, like in surgery department, why do we choose the hemorrhoids and varicose veins? That reasons is very common. See, common is very common. So we try to we have encounter so many common varicose vein cases in our hospital. Many we refer from other departments for varicose vein. So we want to bring insight to the disease and wanted to update on what we've been treating these patients in our department. So why varicose veins are commonly affected in the lower limb? When I say varicose vein, everyone will think about lower limb only. Why? What is the reason behind why lower limbs are commonly affected by varicose veins? Are anti-gravity flow. Blood need to pump against the gravity. So almost on standing position, the pressure going to be at the ankle is 100 millimeter mercury. So this need to be pumped towards the heart against the gravity. So one is anti-gravity, which will causes valves to damage due to the pressures. And also unidirectional flow need to be maintained, and also have a unique venous system in the lower limb, which consists of a superficial venous system, deep venous system, and also the connecting perforator systems. And of course, we need to know about the muscle pumps, which is known as the peripheral heart. So as I said, it's a venous systems. We have a superficial, deep, and perforators. So superficial venous system and great stephanus is the one of the longest vein in the body, which is around 75 centimeter in average. Okay, this is the most commonly affected in the varicose vein. So these are venous valves, which are unidirectional flow valve, which helps in the maintaining the blood to flow in one direction against the gravity towards the heart. So when these valves are damaged, that's when you develop a varicose vein. So perforators, there are two types of perforators. One is a direct perforators, another one is indirect perforators. Direct perforators will connect the deep vein and superficial vein directly, whereas indirect perforators will connect through the muscular veins. So just like a cycle tire, if you imagine, the center part is a deep vein and the outer tube side is the superficial vein. So the connecting things are the perforators. When these perforators are damaged, that's when varicose vein develop, and the blood flow will be from the superficial venous system through the perforators to the deep venous system. So as I was saying, the muscle pump, peripheral heart. So when we walk, the muscle gets squeezed, and these are gastrocnemius muscles will get squeezed, and which causes the increase in the pressure in the calf region, which pumps the blood towards the heart. So what is varicose vein? They are dilated, tortuous, elongated veins in the leg. Usually painful condition. It's usually classified based on the size. Thread veins, reticular veins, and varicose vein based on size. Mostly more than 4 mm is considered as a varicose vein. So risk factors who commonly affected by varicose veins are these are the people who actually get varicose vein. Females are more prone for a varicose vein due to the hormonal changes and everything. And hereditary conditions like Klippel-Trenaunay syndrome, everything have a more prone for varicose vein. Congenitally, they will develop a varicose vein due in the short saphenous vein. So conditions like raised intra-abdominal pressure or in any masses, this also can lead to a varicose vein. And prolonged standing or sitting, that is usually commonly encountered in the workplace related varicose vein. So symptoms, these are the common symptoms. Usually patients present with dull aching pain, usually during the night time, over the end of the day after done with their work. So it's also known as a fatigue leg syndrome or tired leg syndrome. So usually patients develop nighttime cramps, that is the mid of the night, due to after patient is having this edema and everything over the prolonged standing. When they start to take rest, when they elevate the limb, that's when the blood started to drain from the place, which causes the irritation of the nerve ending, which causes also pain. So due to the long standing, again hydrostatic pressures and everything elevated in the lower leg, which just causes edema. Due to edema, the blood started to increase hydrostatic pressure and edema. There will be leaking of the blood into the tissues, which causes release of RBCs, WBCs, and fibrin. This RBCs, which causes hemosiderin deposition, will take place, which causes discoloration and also causes irritation to the nerve ending, which causes itching. So due to scratching, everything, patient might develop a bleeding, and ulceration subsequently will develop. So these are the signs. Based on this signs, we can classify the patient into, based on CEP classification, we have a clinical classification C1 to C6. I'm not going to talk in detail and don't want to bore you all after post lunch. So what all we know from this varicose vein is whether patient having SFJ, SPJ or perfecta incompetent. That's more than enough. And these are more of a documentation purpose. So these are the clinical pictures. Varicose vein, it causes a telangiectasia or reticular veins when this is around 1 mm. So that's a pigmentation. The mouse. The pigmentation of hemocyanin, as I said just now, is due to a hemocyanin deposition which causes a lipodermosclerosis. Severe eczema patient may develop, and also patient can develop venous ulcer. Although it's a superficial ulcer, it will be very painful and it's hard to manage when the patient develops ulcer. Usually patient comes in later stage. This is C6, so patient usually present in this stage with ulcers. This is when we need to treat both varicose vein and the ulcer. So we can evaluate this patient based on a medical history and physical examination and Doppler ultrasound. So Doppler ultrasound is the gold standard for identifying these cases. To evaluating Doppler scan, just three things we need to know from the patient: the presence of any reflux in the deep superficial venous system. We want to know how is the SFJ or SPJ condition. Also wanted to know whether perfectas is there or not. And obviously, we need to know about the obstruction of the deep venous system, which is very much important. If deep venous systems are involved, we will try not to deal with this patient. We will try to do conservative managements. So this based on this B mode ultrasound, as I say, B mode ultrasound with the Doppler ultrasound. So we have clinical pictures. We'll ask the patient can examine the supine position or standing position with Valsalva maneuver. On Doppler scan, we check the SFJ. As in SFJ, we have studied went to this exam question. Mickey Mouse sign will be there. So femoral artery, femoral vein, and long saphenous vein. So we need to identify whether it's dilated or not. We wanted to know whether the dilatation is how much mm is dilated. More than 6 mm is considered to be varicose vein. And we want to know how is the reflux is there or not. Based on reflux, more than 5 seconds, we will come to a conclusion of varicose vein with the Valsalva maneuver. So the blue is blue. Based on blue and red, we'll check for the reflux. If there's going to be a reflux, it will be in the red color. That is towards the probe. Blue is against the probe. As I said just now, this is the blue color one, and the red color one is the reflex. So treatment, there are so many modality of treatment when it comes to varicose vein, from conservative treatment to the surgery and to minimal invasive surgeries. So conservative treatment, we can go ahead with exercises, compression stockings, and we can ask them to do a regular limb elevation, everything. And surgery, we have a saphenofemoral ligation with great saphenous vein stripping. When we go for nowadays, open surgeries are considered as a radical procedure. So patients tend to choose minimally invasive procedures such as endothermal ablation, sclerotherapy, and the other new ones are mechanochemical ablation and endovenous glue. So perfectas can be encountered with subfacial ligation of perforators, and Linton's method are there, and stab avulsion method. So laser is a device that, so what I'm coming to our topic is a laser for a varicose vein. So laser is a device that transforms light into various frequency into chromatic. Radiation is visible, infrared, ultraviolet region, with all waves at the face of capable of mobilizing immense heat and power when focused at a close range. So properties of laser is a monochromicity, directional, and coherent. And monochromicity is like when this one single wavelength is targeted to a tissue. That's when we say it's a monochromicity. Laser have that capacity, whereas the white lights have a multiple chromicity, which causes multiple wavelength of lights will be targeted. So if I go more deep into this, it's most of physics, so I don't want to touch on that. So I want to make it simple. So if we have a laser fiber, three things that takes place when we use a laser for treatment. One is when we use this diode laser in our department, which nanometer of 1470, which is commonly used here for photothermolysis. So when we use the laser fiber, when targeted tissue, three things will take place. One is it will cause steam bubbles will be generated at the tip of the laser. So it will causes a split within lumen, which causes a photolysis. At the same time, it will cause a coagulation of the tissue and can be sealed when you pull in retrograde fashion. And there are chromophores that placed available in the tissue, such as hemoglobin, water, and everything, which absorb the laser, which also causes a denaturation of the collagen and causes a thrombus formation. And obvious, the next thing is direct contact. The heat which causes the tip will causes a carbonized layer over the venous layer, so which causes a sealing of the vessels. So this is what is available in our department. So we uses 147 diode laser, and these are the instrument that we use. We have a J tip, we have a sheath, and we have a needle, which 19 gauge needle, to do a stab at the laser when you wherever you are encountering. And we have a 360-degree fiber, radial fiber, which give a light due to prism effect of the tip. Because 360-degree, it will have a emitting of the lights. So based on this thing, we'll give a spinal anesthesia to the patient, or can be done on the local anesthesia. We'll just pour 4 finger breadth below the knee region. We'll enter the great suppleness vein through the ultrasound guidance. From there, we'll put a sheet. Through the sheet, we'll put a guide wire. Then we'll put a laser. Through laser, we can coagulate the vessel with 1470 degree. When we are doing this, we also give a tumescent fluid, which causes a perivenous constriction of the vein. At the same time, it will also minimize the spread of the laser to the adjacent tissues. Based on this, we can ablate the whole length, but we should make sure that it is 2.5 centimeter below the saphenofemoral junction and shouldn't enter into the saphenofemoral junction to avoid any nidus for DVT. It can be done in a daycare procedure. Patient have minimized pain. So these are the benefits of doing laser therapy for varicose vein. Can done with a daycare procedure. We can have a wide surgical incision. There's no incision takes place. Only minimally invasive. Can do under a small stab is enough. It have a high success rate. There are studies which shows around 95% of success rate compared to the same as a radical procedure, which I said, Tandem procedure. And lower post-op pain, patient have minimized pain where the amount of use of analgesics be reduced, and quicker recovery. And only thing that we need to put is a grade 2 compressive stocking for the 2 weeks post surgery. We can follow up the patient, and the cost effective compared to other hospitals. I think we have doing in the better rates, so very much cost effective in our hospital, and can treat both the leg at one sitting, and cosmetic improvement also better. We don't have the amount of hematoma that develops post surgery. Everything will be minimized. So in our department, we also do a EBLA with other therapies, which is called hybrid therapies. When you do a sclerosant, we have a sclerotherapy for varicose vein. We encounter for small, as I say, telangiectasia reticular veins, which can be encountered with sclerotherapy. So EBLA combined with sclerotherapy can be done. And in certain cases, based on the clinical picture or a severity of the disease, we also go for a EBLA with flush ligation and plus SFJ. And we have a EBLA with perforator ligations for the only perforator incompetent patients. And also we do a stab avulsion for the perforators. Thank you. So basically it's done under the guidance of ultrasound. We place an ultrasound and we'll put a 19 gauge needle, and we'll put a guide wire. Through the guide wire, we'll put a sheet, then followed by remove the guide wire, we'll put a laser fiber, which is a radial bare tip fiber. We enter that. It will have a tip of it will have a prism effect in the tip, which causes emitting of the laser at the tip. So we give a tumescent before we doing the firing of the laser, followed by a laser, which causes the kind of photocoagulation, photothermolysis, which will cause constriction of the vein. Thank you. So I need a clinical picture. I need to examine first. I need a history. Then I need a duplicate. So based on your severity, based on the SFJ and any varicose veins. That's the reason we presenting here today. Yes, sir. So the reason is like patient usually present to a later stage because of we give medically unimportant to those people. People think there's more of cosmetic issues and they ignore to come for medical attention. Yes, sir. That's why sir, I need to evaluate before I see.
So people come to us at a very late stage and they want us to provide cosmesis even if they have an ulcer. They want cosmetic surgery, sir, but already the cosmesis has gone already.
CEAP.
So up to C3, sir, generally it can be managed conservatively with stockings. No, you do not, sorry, sir. But vast majority of the patients, more than 80% of them, will require only all these conservative measures like compression stockings and all. Yeah, so
That's
we
what
have to
sir-
impress upon them, sir. So suppose if it is followed, then it's usually say static, but otherwise the disease progresses, and once it reaches C4 and above, they'll need some form of intervention. Once they develop ulcer, they'll need a 4-layer compression bandage for healing the ulcer, and probably the treatment of the primary disease, either in the form of surgery or nowadays laser ablations. Sir, one of the indications is we need a straight vein, but sometimes it's possible to manipulate through small, tortuous veins. But if it is very tortuous, then we may not be able to manipulate it, and then we may need to make another puncture and make another entry to get in the. Yeah, definitely, sir.
Otherwise, can do from retrograde, sir.
Even if open surgery was the same problem. So the stripper when we pass, it may not pass entirely. So we might need to take multiple entries. So the main advantage is daycare procedure gives the same results, less pain, and more cosmesis and early recovery. So these are that. And very thin patients where the skin is very thin, sometimes it may be a contraindication because of the heat it generates. So that's why we use tumescence to prevent the heat from being transmitted to the skin. So I have to examine you.
Exactly. Can be done, sir. Can be done. Yes, sir. It's available, sir. We have the around 45 centimeter laser fiber, sir. Only the tip. Radial fiber, radial bare fiber. Diode laser. Yes, that is using conical fibers. Here we use radial fiber. Yes. Yeah, everything is available here. We have in both BS block and A block, sir. Only the price varies, sir.
Sheikh, last question. Sir. See, one obese patient had venous ulcer.
Yes, sir.
For varicose vein, he did the surgery, but recurrent the venous ulcer comes. The patient is obese. So, how do you manage the patient?
I will ask the patient to consult Dr. Balamurugan, undergo obesity surgery, and come back to us.
See,
Undergo obesity surgery first.
actually, sir, the answer what I expected is weight loss, but not surgery. Thanks, sir. Madam, weight loss podi. Enkita vada. Weight loss podi.
Thank you again.
Thank you, Sheikh. Wonderful presentation.
Thank you, sir, ma'am. As we approach the conclusion of today's first session, PSG Med Talk, so I would like to extend a warm welcome to our esteemed Professor Dr. Dinakar Rai, sir, from the Department of Orthopedics, who will now facilitate the speakers and moderator. I request Dr. Vishnuvardhan, sir, to come and collect the memento from. I welcome Dr. Chitra ma'am to come and collect the memento. Thank you, sir. Moving on to the next session. So we are going to have an engaging case-based panel discussion on a highly relevant topic, Diabesity, collaborative solutions. We are honored to have our chief guest, Dr. Santosh Jacob, an expert in orthopedics and sport medicine from PSG Hospital, Chennai, who will share his invaluable insights on his intersection of obesity and diabetes and how collaborative approaches can provide more holistic care. The panel will be moderated by Dr. S. Balmurugan, consultant in bariatric and metabolic surgery.
So first of all, thank you MedTalks team for organizing in this in a very short notice. See, today morning we had a patient support group meeting, so I thought of inviting Dr. Santosh Jacob sir for moderating a patient support group meeting. So today this topic about a patient support group meeting was about post-bariatric surgery, about body contouring. So after weight loss, patient have to build up muscle mass. So we thought of inviting him, so give idea about how to build muscle mass. See, as far as you know, Dr. Santosh Jacob sir is an orthopedician at PSG Hospital, Chennai. But more than that, he is a very much social media influencer for a diet and physical activity. So, and we thought of inviting him for a panelist about diabesity collaborative solutions also. See, why this topic is mandatory. So that is what our recent days question is about. See, in upcoming days and the last 2 years, medical management for diabetes is also getting improved, and with obesity even. So managing obesity and diabetes comes to the relevant. So in the upcoming months, I think there are 2 other GLP-1 antagonists which is going to release, like Ozempic, that is semaglutide, and in one another injection form is trapezoid. So we need to know how to manage diabetes and obesity. See, bariatric surgery was previously the only option to reduce weight loss and other comorbidities. But for obesity management, medical management is getting improved. So we need to know where the medical managers have to be applied and where the surgical manager has to be applied. So first, and I wanted to thank my general surgery department, where in front of them I was a student, and right now I'm just presenting in front of them. That is the most honored thing for me. Thank you, sir. Thank you, sir. So first question to all, for the audience only. See, yarkalla weight loss agano, and if someone gains weight and who has diabetes in future, if we think so, it should not happen. But if you gain on weight and put on weight, will you go with medicine or with bariatric surgery? Just small question. Madam? But diabetes is not coming under control if weight is not coming under control, madam. Just question them, madam. Madam, you are not going to put on weight. Pakatla Chitra madam poda matang, but irundala ketukla appdin paathan. Please. Sorry. So, sir, to all the panelists. So first I wanted to ask with Varun, starting from Varun. Sir, do you think the obesity reflects as an inability of a person to manage their health, or it is a failure of the able person to act on it? What is your choice?
See, if obesity is due to a genetic reason or due to a hereditary disease, then it's because of the condition they're not able to lose weight. Whereas if it is due to the lifestyle what they're having, then it's the person's inability to do it.
Sir, what is your, Ramoti sir, please, sir, what is your answer in this regarding to it is inability of a person or a failure of an able person, sir?
it reflects a person's inability to manage their health. That's what I feel.
Okay, sir. Sir, you have seen more obese patients, and since you are even coming from metropolitan city and being a famous social media influencer, you have seen many obese patients because you talk about obesity, you fight for obesity, and
I
ask
have been
people to
obese.
reduce. Yes, sir. Yes, sir. Obviously. So, what do you think, sir? It is an inability of a person or failure of an able person to do what?
There is just one orifice in our body through which energy can enter. That orifice is guarded by muscles and teeth. If energy doesn't go through that, we do not gain weight mostly. So I think primarily if you have childhood obesity, where you have been taught to eat in a certain way, fed certain foods when you were young, and your entire hunger control is off the hook, and you're an emotionally eating child, adolescent, and young adult, then I think the blame is not too much on the individual, but on the upbringing. I mean the parents, right? So I think it's 70-30 in adults, 70 being the person's responsibility, and I think it's completely opposite in children, 70 being the parents' responsibility. I think right now, Chennai has 40% of school children in Chennai are overweight. And in that, 21% are overweight and 19% are obese. So I think it's mixed, and it's also the community accepting obesity like that it can't be changed. So obesity is a disease which starts off as a habit. So I think that's the combination.
Sir, what is the percentage of your patient that you see in your OPD are obese in a day?
80%.
80% of them are obese.
Yeah, because 20% of them are athletes, so they are pretty lean.
That's great, sir. So to Tyagaran, sir. So how do you see, sir? Because you have seen many number of obese patients in your practice, because you were treating in obese patients in the past also when you were in US. So what is your perception about obesity? Is a failure of an able person or inability of a person, sir?
So again, Dr. Santosh shared that, I would give the kind of similar numbers, 70-30, I would say. Obesity is a complex disorder. It's just not, energy, plus energy minus. It doesn't equate like that. Genetic factors are there, epigenetic factors are there, environmental factors are there. So, and, obesity was not there, like say 100 years ago, right? So, this is a disease of our times. So, not everything can be blamed on the individual as only. So, but, if somebody is obese or overweight and if they are not able to lose weight, and again, there are multiple factors that contributes to that. So sometimes it's just, telling them to, eat less and exercise more doesn't work. So it has to be approached in a much different way. That's why we are talking about today here in the conference here to have a holistic approach and, multidisciplinary approach towards obesity. So I think it's much more complex, I would say, but I would give similar numbers like, it's at least a 30% the individual's responsibility to take care of their health. Yes.
So thank you, sir. Thank you, sir. Madam, as a chief dietitian and head of the bariatric nutrition department also, how do you see this, madam? Managing, again, inability of a person or a failure of an able person?
Sir, both. Like sometimes the individual has to decide to lose weight. And second, the other factors like family members, they have to support, and the person needs the resources and motivation, and so many other factors are there. So it again depends on the individual also. So
true, madam. True. And what is as a bariatric nutrition, what is the percentage of obese patient that you see in your OPD?
In the obesity clinics, 100%.
100%. That is what the problem here is, sir. See, when we treat about obesity, since we see only obese patient, there are more things that we are able to highlight. So to summarize this thing, when we see it as more of inability, because we see people coming to doctors to do surgery or to get medicines, they must have some guts to come to a doctor first. So after getting all treated by themselves, they are only coming to the doctors. So when we see that to have these things, so we need to analyze their sleep. So how much excess body weight the burden is, and moreover that how much that excess body weight burden is decreasing their physical activity, and again psychological issues and these things. So when we assess all these things, we are able to see whether it is an inability of a person or a failure of an individual. As we said, both the percentage is more of a failure of an able person, because the persons whatever they come to hospital, it's failure of able person, because that obesity turns as disease, so only they are coming to hospital. If they have been a very good active person, they would have not come to the hospital itself. So that is the difference. So the next question, sir, what is the pathological reasons behind pathophysical reasons behind obesity and type 2 diabetes, sir? And Tyagaran, sir, please, sir.
So, like I said earlier, genetic factors are there. Not like just a single gene polymorphisms, but polygenic mechanisms underlie obesity. Like the well-known one is the FTO gene, but even that only can explain about 6 to 10% of obese people, maybe even less. So the rest are all determined by a whole lot of other things. Like I said, epigenetic factors. Some of things are decided when we are in our mother's uterus. So our mother's nutritional status plays a role. The condition she lived in, what are all the factors that she was exposed to may have an influence. The medicine she took when she was pregnant. These may also influence whether we are going to be obese when we are adolescent and adult. Those things are factors. And you mentioned just the assessing the obesity by looking at their exercise pattern, their sleep pattern, what sort of work they do, what kind of shifts they do. So all these would have an influence. So environmental factors like the pollution they are exposed to might have an influence on the development of obesity as well as diabetes. So it's a multifactorial, multi-pathophysiological process that underlies obesity. And diet also plays a factor, and exercise also, lack of physical activity also plays a factor. Those are the most important factors. Yes.
Sir, in children, nowadays obesity ratio is increasing actually. When sir said after evolution only, we are just getting into more an obese pattern right now, because more is of lifestyle. Like accordingly, there was one film in cartoon film Wall-E. I think there was one cartoon film Wall-E where all the people will live in space, and after living in space, there won't be much of any physical activity. They will be increasing in weight. But same thing nowadays we are seeing in children, but the percentage of obesity is increasing. That too after COVID. So apart from lifestyle, what are the things that we need to evaluate in children if they are getting obese?
So, being an endocrinologist, I would just start with like any hormonal issues. I would say whether they have any hypothyroidism, if there is a stunting of the height gain, then maybe we should look into whether they have, say excess cortisol like a Cushing's. Those things should be evaluated. And, again, depends on the eating pattern and their neonatal history. If you have any suspicion for if there's abnormal weight gain, then you should, evaluate for monogenic diabetes syndromes. Those we should be looking into, Prader-Willi and so on and so forth. Other than that, it's just like anybody else, like any other adult with diabetes or obesity. So you look into, what are the environmental factors that's contributing to the development of excess weight gain, and evaluate for comorbidities, whether they are having, or maybe starting off diabetes. So those things have to be evaluated even in a child.
Madam, and how do you handle this patient when a patient comes to your obesity clinic? So how do you handle these patients, and what all is history that you take, and how do you manage these patients, ma'am? So basically about taking a history.
So initially we'll have to collect all details related to their anthropometrics and if possible body composition analysis, then about their food habits, their daily routine timings, the work time, at what time they work, they start, and their food habits, their sleep pattern, and apart from that, if they have any hobbies. So generally we'll have to collect all these details so that we can, in their routine, we can fit in their changes, modifications in their diet or exercise patterns can be done. So unless we collect all this history, it will be difficult for us to prescribe diet or an exercise.
Since you talked about sleep more importantly, as a dietitian, will you evaluate fully about sleep? So what all things that you look forward into it, ma'am?
So we just ask them how many hours of good sleep they have and at what time they start sleeping. Many say I sleep for 8 hours, but they go to sleep only by 1 o'clock or 2 o'clock. So we generally have to have a early sleep. So that sleep pattern is very important, number of hours of sleep and at what time they go to sleep and is it disturbed. And we also ask them in case they have any sleep disturbances, what kind of food they had for the dinner, at what time they had their meal. So
Right. So if patient wants to, again, if we had decided that patient is again a diet and lifestyle modification patient alone, because patient is not too much obese, don't have any metabolic syndrome. So patient is just only 10-15 kg excess body weight. So how do you manage this patient and what kind of diet, if they wanted to prescribe, what kind of diet you give? Do you have any fixed diet charts or do you follow some kind of system pattern? What do you follow?
sir, it diets has to be personalized and tailor-made because each one of us have different taste preferences and the method of cooking at home is different and our work timings are different. So we'll have to see to it that we give a personalized tailor-made diet charts with their all these factors and also include lots of high fiber foods, lean meat, and try to include lots of complex carbohydrates and check on the diet intake and then modify accordingly.
See, as we all know that when a patient wants to follow some diet and physical activity, thing about patient complaints to diet, we say that I'm not able to follow some diet for long term. That is because they are not able to customize their diet plan. So they think that this is what my diet pattern is. That person to person, it might differ. But whatever, if it succeeds to anyone, it doesn't mean that it has to succeed to me.
That's right.
So that makes the failure of the diet for the patients to follow some diet. So it has to be again customized diet and the patient has to be followed regularly and make them believe it will work actually. So
First, we have to see to it that they're comfortable with us, open with us. And we should not insist on weight loss, number of kgs you have to reduce. But what slight modifications that they can do in their routine so that they will realize that they are losing weight.
Sir, for Ramamurthy sir, please sir. Sir, how do you address mobility challenges in patients with obesity, especially those experiencing knee joint or any back pain?
Okay. So the patient is already obese and he has a osteoarthritis knee. If you ask them to go for walking or any aerobic activity that will worsen the pain, so it's a very tricky situation. So in this situation, the alternate exercise program like aquatic training, walking in the water or cycling, static cycling, swimming, all this will help the patient. Okay. Not loading the knee joint.
Not loading too much of knee joint.
Offloading the knee joint.
Sir, as an orthopedician, how do you wanted to approach these patients? Do you have any intervention? What kind of management that you wanted to advise from as an orthopedician?
We have a protocol we follow. So basically the idea is the pain affecting your ability to exercise? So to simply put it, if your quadriceps and your hamstrings and your calf muscles and your glute muscles are strong, when we walk, the weight which goes through the knee or the stress on the knee joint is lesser. So the idea of any pain management in a degenerative condition is to make sure that the patients are able to exercise in order to strengthen the muscles. So medications, if they help to exercise. Like for example, as Sir said, in order to do aquatic exercises or non-loading exercises. Then we give a combination of injections. It could be either hyaluronic acid or ozone or PRP. Then we ask them to exercise. As they keep exercising and they strengthen their muscles, overall their ability to exercise increases. One. Second, exercise has a fabulous adaptation called neurological adaptation, where you get new nerves in order to execute the activity with the same amount of muscle, right? Even if your size doesn't increase, nerve cells, motor units will increase and they will be able to do the activity better. So for us, if there isn't any significant varus, it is any methodology with which their inflammation reduces enough so that they can load their knee joint and exercise.
So the next question I wanted to, since we have talked about more about sleep, that too in obese individual, the more people are affected with sleep apnea. So that too, when a patient even 30 kgs or 30 kgs excess body weight itself, they are able to have sleep apnea. So how do you evaluate these patients? Only snoring is itself enough, or do you wanted us to evaluate so much better, because sleep apnea affects their whole sleep, so that next day they won't be able to do any physical activity. So how do you wanted to analyze these patients' obese sleep apnea?
So basically, when we're talking about snoring and obesity, we are dealing with a condition broadly called as the sleep disordered breathing. It starts from snoring. It also has other spectrum, which includes upper airway resistance, OSA, obesity hypoventilation syndrome. So now answering to your question of whether snoring and obesity will correlate. So many a times, patients who snore need not necessarily be obese. There can be other reasons for them to snore. So one important factor is any upper airway obstruction. It could be a deviated nasal septum or a nasal polyp. So that could be a reason for them to snore. Whereas patients who are obese, most of them, they fit into this spectrum of sleep disordered breathing. Answering to your question of how to diagnose it, clinically, the most important thing is the history. And the most important is you should ask the bed partner and not the patient. Because many a times the patients may not be aware whether they are snoring, and they may not be aware whether they had apneas and all. So the bed partner would tell that the patient was snoring, the volume would gradually increase. Suddenly there will not be any sound, and again they will either start to snore or they wake up with a choking sensation. So that is a typical history what the patient's attenders give. And after that, we have a lot of questions to assess their excessive daytime sleepiness, which includes Epworth Sleepiness Scale. And one important screening tool, which every doctor who comes across an obese patient, is the Stop Bang questionnaire, which stands for snoring, tiredness, observed apneas. P stands for high blood pressure. B for BMI more than 35. A, age more than 50. N is neck circumference more than 40 centimeters. And G is male gender. So if the patient has a score of more than 5, then there is a high risk for the patient to have OSA. And the confirmatory tool is, of course, to get a sleep study done. So that answers your question.
And more than that, whatever we patients say, whenever we ask, apart from stop band scoring, we ask them how much pillows they keep for sleeping, because the patients who have severe sleep apnea, they keep at least more than 2 to 3 pillows, and they cannot sleep straight with the roof facing up. They need to turn to one side alone, or they need to face upside down. And by sitting, they feel more comfortable.
Now that is basically because patients who are obese have a thick tongue. When they lie on a supine position, there is a high chance that the tongue falls backwards. That itself will cause choking sensation.
And more of visceral fat also, which pushes the diaphragm so that the lung volume decreases actually.
Yeah, so if you see, the lung is the most dynamic organ and the bigger organ. It needs a lot of space to move around. Normally, the diaphragm contracts and creating a negative interthoracic pressure, and the patient breathes. Whereas in patients who are obese, because of the visceral fat and the fatty liver, the diaphragm doesn't have much of place to contract. So, and if you also see that is thick neck muscles, which also obstructs the airflow. So these are the reasons why patients develop obstructive sleep apnea.
Thank you. See, and madam, I just wanted to, from the dietary perspective, so when the sleep is getting disturbed, the patients, how do the physiologically they are affected since the patients sleep is getting disturbed, because their cycle is getting disturbed. So there must be some changes with diet.
Sir, their intake is disturbed. They feel nauseated sometimes, and when they have sometimes heartburn. And so what happens if their sleep is disturbed? Their eating time varies, and in case they go to bed late, they snack a lot. So the junk intake increases if their sleep is disturbed.
True. See, when their sleep cycle is getting disturbed, they try to get up very late. So at that time, they will feel very hunger. So they will at least eat 1 or 2 100 or 200, 300 calories excess. So with there's no physical activity because sleep is getting disturbed. Obviously, they will put on weight alone. How do you manage this emotional stress eating, madam?
Emotional stress eating, like we'll have to help them in scheduling their day. And in case they feel they are stressed and they want to eat something, we have to give a healthy choices. Instead of the junk food, we can tell them to have some healthy nuts, healthy fruit choices, or dried fruits like that. So that if they feel they have to eat something, tell them to eat this, and mindful eating at that time. Eat slowly, drink lots of water, because hydration is important. That will suppress your hunger and elevate your mood also.
And with the sleep is getting disturbed and patient is obese, obviously, I think Varun should have started with somewhere CPAP or BiPAP. So only the sleep cycle is going to get disturbed. So obviously with diet and Varun CPAP or BiPAP, I think everything is going to get all right for that patient. So again, it has to be combined management. Sir, for orthopedics, Santosh Jacob, sir. So how many patients request sedatives for orthopedic issues related to obesity? Because many patients, sir, I have severe body pain. I need some sedatives to sleep.
Sleeping pills, you mean? Sleeping pills like Alprax or stuff like that. Yeah, almost everybody asks me.
Everybody asks.
Yeah.
The problem here is, sir, when the sleep cycle is getting disturbed, that is because of severe sleep apnea. So when the severe sleep apnea is getting, even with the sedatives, they are not going to have adequate sleep. So again, next day they are going to either feel very tired or drowsy. So again, that will increase their weight alone. So how do you counsel them for physical activity if you wanted to ask them to go for exercise with some mobility restricted issues with overweight? So how do you motivate them? So because you are more of social media motivator, so that you might be seeing these kind of patients more, because patients come to sit and talk with you alone.
Yeah, yes, you're right. So my practice is 80% orthopedics and sports medicine, 20% is obesity, diabetes, muscle building because of that. Sorry, can you repeat the question again so that
since the patient comes to you for with any mobility restricted issues and they wanted to ask how to do exercises, because of severe sleep apnea and obesity, they'll feel very tired. But how do you counsel? Because they wanted you to motivate and ask you to tell something to relief of these patients.
Yeah. So the first thing is, I find if it's a male, right, to assess their hormones, testosterone, to show them that their testosterone is going down, really motivates them. The second thing is to do a DEXA scan or an in-body scan and to show them that your lean mass is really, really low. Okay, that's why you're feeling like this. And most importantly, I tell them that, see, anyway, life expectancy is increasing, right? We are going to keep you alive till 90 or 100, but moving is completely in your hands. And you have such low muscle mass at 35 or 40. I do DEXA scans on a regular basis for women and for men. You'll be surprised to hear that even women around 25 to 35 who have a normal BMI have body fat percentage of around 45 to 50. So it's all hidden obesity. That means that their lean mass is even lower. So discussing about their body composition, I felt has really motivated people to do so.
Sir, in Tamil Nadu, when you see that more number of, today morning also you must have seen of patients, the number of female patients are very high. For the who has come for bariatric surgery, in the morning you must have seen some.
Yes, I did that.
See, that is because the patients people have started accepting obesity as their own. With the more the mentality, the more you ask them, when did you put on weight? Sir, after marriage only I started putting on weight. The first answer that comes from them is that thing. Because after marriage, the commitments increases. Stress also. So,
I'm not saying this.
Sir, how do you overcome these barriers, sir? Ramoti, sir, please, sir. Sir, how do you overcome these barriers to ensure that stay active while managing sleep-related issues, sir?
That is
சாரோட போட்டோ காட்டினாலே போதும், நானே எப்போ முடிய போகுது சார் கிட்ட பேசலாம் என்ன சீக்ரெட்னு வெயிட் பண்ணிட்டு இருக்கேன்.
Sir also follows great diet, sir. Sir is it is ரொம்ப strict on diet and strict on lifestyle also.
Okay, the secret is 2 meal a day, nothing in between strictly. Then regular Surya Namaskar every day. Then floor exercises. Sunday 15 to 21 kilometers running. That's the secret. Right. I am of strong opinion. A doctor must be a role model for his patients. I have a big belly and tell the patient, hey, reduce your weight, man. I cannot say. Okay. So I want to be a role model for my patients. Also, I am prone to develop diabetes. So I am escaping from this by maintaining my BMI. Right. In answering your questions, you got to keep on talking to the patient and motivate them. And with my personal experience, I will teach them pranayama and Surya Namaskar. That will help them.
Thank you so much, sir. Thank you, sir. Regarding weight loss, what are the difficulties and how do you address sleep apnea in such patient? What symptoms do you commonly observe? So, what are the weight? Already you have answered for the second question, but regarding weight loss, what are the difficulties that you face when you ask them to go for weight loss?
So, most of the patients who are obese, they don't sleep well. So, morning they end up waking up very tired. They will not be motivated to do exercises. Unless they are fresh and brisk, they will not be able to do the exercises. So in those scenarios, we'll tell them after the sleep study that you are having a significant OSA. And if that is being corrected, you'll feel fresh in the morning so that you can do your regular physical activities. So that is how we motivate them.
But some patients in your practice, you must have seen that when you ask them to keep CPAP or BiPAP, I think most of the patients, are they following it or not? Because it is not because they are listening to it. They listen. They also know that this is what the problem is. But there are some difficulties they face it because you and me have faced the same challenge when we asked to keep the patients. So just wanted to tell people that these things can be managed. So only the question.
There are many reasons why patients don't become compliant to CPAP. One is the foreign body sensation. So they'll feel suffocated. They might feel that the pressure is higher. So these are the various factors why people don't tolerate CPAP. So there are studies showing that if they're able to accept it within the first 2 weeks of starting treatment, there is a higher chance that they end up using it on a regular basis. So the initial period, the way how you counsel the patient and how you tell them the importance of CPAP, those are more important before starting it. Just telling them you start CPAP, it doesn't work like that.
And nowadays, the sleep technicians are just easily following up the patient, and they themselves keep the track on the patient so that the patient compliance is better. Because they ask, "Sir, if your mouth is getting dry or not, let's take a humidifier." These people are doing a good job actually.
Yeah.
So, again, the next question is, Sir Tyagaran sir. Sir, what all obesity-related comorbidities? As we all know that there are many obesity-related comorbidities with the patient. But what is the role of GLP-1 receptor agonist, whatever we are getting into line, and SGLT2 inhibitors in managing diabesity?
Okay, so since we are calling it diabetes, I will answer this, without any hesitation there. So SGLT2 inhibitors, yes, it's a diabetes drug. It's not an obesity drug. It's not approved for obesity in any country in the world. SGLT2 inhibitors, again, they primarily excrete the glucose through the urine. So you get a net calorie loss from the body. So that way you can lose a minimum amount of weight, I would say 2 to 3 kilos. And some patients may regain this weight also. Certain SGLT2 inhibitors, which again we have finding it difficult to get nowadays, like the 300 milligram of canagliflozin, may have even more glucose excretion. So you might get a little bit extra weight loss through that. But otherwise, SGLT inhibitors, I wouldn't use just for weight loss. Maybe I would as an additional drug apart from that. But besides that, this is a great drug for management of diabetes themselves. And then also it has many extra benefits in terms of cardiovascular and kidney benefits. So it's a great class of drugs. So coming to GLP-1, again, as of now, what I want to say after this would be off-label use only, because they are not approved for weight loss as such. They are only approved for diabetes in India. Again, the newer medicines Dr. Balagunan mentioned earlier, the tirzepatide, the panel has approved the use of tirzepatide for the management of obesity, but has not come to the market yet. And soon the DCGI will approve it, and so on and so forth. And there are multiple other drugs in the similar category that will be coming in. These are called incretin type of medicines. GLP-1 is the prototype, if you will. The semaglutide is the one. Before that, we used to have liraglutide. Again, maybe the 3 milligram dose was not available in India earlier, but that was an approved drug for obesity also. So,
how does the GLP-1 analogs actually work?
Okay. So, how do they work? So these are actually natural endogenous hormones found in the body. They are GI hormones. They are secreted in the gut. So, what they do is, they depends on the glucose level. They will increase the insulin secretion from the beta cells and decrease the glucagon secretion from the alpha cells, but also promote satiety. Or a feeling of satiation in the stomach, so they feel the stomach full, and delay the emptying of the stomach, so the patient feels full early. But also they can exert effects centrally in the central nervous system, in the appetite centers and the satiety centers in the hypothalamus, and make the patient feel full for longer periods of time. So these medications that are now available, so they are synthetically manufactured molecules of that act on the GLP receptors. They are not degraded by the natural enzymes that break the natural GLP-1. So they stay in the body longer. So their half-life is longer. So they act on the pancreas. They act on the gut. They act on the central nervous system for longer periods of time. So they are like, you can say they are like 100 times more powerful than the endogenous GLP-1. So but thereby they change the way the glucose is controlled. So there's less glucose in the blood because more insulin is secreted, and less glucagon is secreted. So glucose output from the liver is lower. Again, they make the stomach feel full for a longer period of time, so the patient doesn't get hungry again. And also, since they act on the hypothalamus, so the patient doesn't feel hungry for longer periods of time also. So that's how they work. They also have multiple other mechanisms whereby they help the kidneys and the heart and so on and so forth. They have receptors all over the body, so they act directly on the other organs as well. But these are the main mechanisms by which they may work on getting the diabetes better and also have very good weight loss.
Sir, thank you so much, sir. Actually, it is again, when the GLP-1s comes around pipeline, it is a very great drug actually. Next to other drugs, there is no, as such, we are not facing any difficulties. The thing is about is understanding it is without this GLP-1 analogs also, it comes by, again, it causes satiety, and by reducing the gastroparesis also. So it has to be again managed by a dietitian. Since time is getting by 5 o'clock, yes, our institution everyone has to leave. I just wanted to skip to last part because time is, and after that we need to ask audience also to give some questions. So, sir, again, what is the percentage of weight loss expected by GLP-1? And is bariatric surgery an option, or how would it impact? Is bariatric surgery is considered an option? Whether GLP-1 analogs can overcome bariatric surgery?
I'm sorry, I missed the last part.
Sir, actually, sorry, sir, 1 second. So, what is the percentage of weight loss expected in when you are using a GLP-1?
Okay.
And if GLP-1 analogs can overcome bariatric surgery?
Okay. So yes. So for the first question, the currently available GLP-1, the injectable semaglutide at the maximum dose of 2.4 milligrams subcutaneously weekly may get up to 15% of your total body weight. I'm not talking about excess body weight, but 10 to 15% of your total body weight. These are numbers that come from the study. So, individual variations may be there. There may be genotypical variations in the GLP receptors in an individual person. They may be non-responders. So, if your patient doesn't lose 10 kilos or 15 kilos, you can't say, this medicine doesn't work. It may have individual variability. But on a mean average, 10 to 15% of body weight can be lost. The newer medicines, the GLP-1 plus the GIP-1, the GLP-1 plus the GIP-1 antagonist, the GLP, GIP, GCP, the glucagon receptor, these medications are coming out soon. So they can go even more than 20% of your total body weight can be lost. So a person can go from, say, 100 kilos to 80 kilos in, like, say, 12-week period time. So those are coming out, and it's very possible. As for whether they can, just replace bariatric surgery, I think that's how I take the question. So maybe not for all the patients. The patients who are going to need the bariatric surgery are still going to need the bariatric surgery. But maybe some level of patients whom we are contemplating bariatric surgery. Maybe some of them may be managed with these kind of medications rather than going for bariatric surgery. And just one additional point: tirzepatide is now approved for management of sleep apnea. FDA has approved it for the management of sleep apnea in the US. So amazing times.
Actually, sir, as the medicines also and bariatric surgery also have some indications. See, bariatric surgery also, we are doing bariatric surgery as, we have Indian guidelines where we are doing surgery for people who are more than 35 without any comorbidities. For BMI of 30 with diabetes, or else we don't do bariatric surgery itself. We don't advise them also. If patients even comes to also, we don't do surgery. Again, with the medicines, with the surgery, with the medicines also, yes, for this patients, if we give, it has a very good weight loss pattern also with the diabetes control even. Sir, to the orthopedic, how do you see this medicines for practice, and do you feel any complications you have faced when you are treating them? Do you feel that after patients with on these medicines, do you feel any complication happen to anything related to orthopedic issues?
So I have been following up a few patients who are on semaglutide for weight loss. They are not able to get off it. The weight is coming back. And if they do not change their habits, build muscle the reason why I am pro semaglutide or any of these is, it's like you have a 50-meter added advantage in a race, because you start off 20 kilos lesser, building muscle mass rather than from the main point. But if you're not able to take advantage of your weight loss and build muscle and change your eating habits, you're always going to be on semaglutide.
Thank you so much, sir. See, thank you so much for a panel for just giving insights about what is weight loss, about medicines, and what is bariatric surgery. See, as we all know that yes, it is going to be when in future obesity management is going to be holistic management. See, the panelists who are all sitting over here are going to help the persons for doing some physical activity and correcting the sleep apnea, rehabilitating the obese patient. As orthopedician needs to treat that patient in their inability, and as endocrinologist, as a dietitian, this team is going to treat the obese patients in future. So only today we have started an obesity clinic in our hospital, sir. So where the dietitians has to see these patients and take a history. They will take a history of a severe sleep apnea and mobility issues and endocrinological issues. And again, they will be able to refer if a patient walks in and have been referred. So as an obesity clinic, dietitian will be able to change this pattern in future, because this team might be helpful. Without correcting the sleep, weight loss is not going to happen. So thank you so much, sir. So any questions? So because of short time, I just wanted to skip all the questions. So any questions, we can just go on with it. Please.
Any questions from the audience side?
Just a comment.
Please.
Whenever you are treating obesity, mainly in relation to the diet, it is not enough if you treat only the patient, you should treat the full family. If you are sitting at home and eating, munching food daily and have a obese patient next day, he can never control himself.
Sir, what we do is we counsel the family also, because if the patient is a male member, we have the wife to cook for the patient. So we train her. We tell her how to cook, the method of cooking, which is better for that person, and how it has to be taken. So the wife and husband, they get counseled. And we also motivate them to change the habits of the children also, if they have children at home.
Then there are some difficulties what the patients share us. If you are not giving food according to their liking, they are not following it for long term, sir. And next thing is, if we give exotic foods as a diet to them, again they say, I'm not able to get this, I'm not able to follow it. And the third thing is, if I wanted to cook, if I wanted to follow some diet, and other family members following different diet, I'm not able to follow it. So these things, if we correct it from the start, if I need to have some diet, if they give it to me according to my liking, I'm able to follow it.
Usually a dietitian gives a very long diet list. Because the long that is very, very difficult to follow.
It's not like that, sir. We have to sit one-on-one with the patient and talk. They have to have time to spend with us at least 1 hour so that we can have a good rapport and discuss. See, we need to know the routine from morning to night, what they eat, how much they eat, what is their preferences, and we'll have to just modify. In case they are taking lots of junk.
Modification is the keyword and quantity is the keyword.
Yes,
Two
sir.
keywords. Modification.
Mindful eating is very important, and the family time is very important.
One question to Kavita. What's your opinion on milk? Is milk a source of obesity, mainly in kids?
Milk may not be the source of obesity, sir, but where you add the milk to what and how much you take, it again, the combination of foods.
Usually,
matters.
mummies have got a tendency to keep on feeding kids with a lot of milk. And I think most of the milks which are available in the market now are sourced from cows which have been, fed with hormones. The same hormones come into the milk of which is sold.
We have several other alternative sources, sir. We have the protein sources where we can get almond milk and other soy milk, and we have alternatives. It's not.
But routinely, milk is the one that's commonly used, and multiple things. One thing is obesity and things like PCOD.
In general, in case we have to lose weight or some patients will have bloating and other things, we try to tell them to avoid milk. Maybe they can include curds, avoid milk. And for South Indians, wheat actually helps in reducing weight. If you cut down on wheat products, we have seen patients who have cut down on wheat products and stay away from milk, they are able to lose weight.
Is wheat preferred to rice?
For South Indians, rice is preferred over wheat.
Sir, actually 100 grams of rice contains, sir,
All the cereals have the same calorific value. It is how you prepare it and what you take.
So 100 grams of rice contains 125 to 130 calories. 100 grams of wheat contains 90 to 95 calories. Only 20-30 calories.
No, but common question is, chapati சாப்பிடலாமா?
Sir, chapati சாப்பிட்டா weight reduce ஆகும்னு எந்த தியரியும் இல்லை. நீங்க ரைஸ் சாப்பிட்டாலும் சப்பாத்தி சாப்பிட்டாலும் எவ்வளவு சாப்பிடுறீங்க, அது கூட என்ன சைட் டிஷ் வச்சு சாப்பிடுறீங்க, and at what time you eat, how much you eat, and in between.
நாங்க ஒரு क्वेश्चन வச்சிருக்கோம். இப்போ மேடம் எல்லாம் கையில கிண்ணத்தை வச்சு சுத்திட்டு இருக்காங்க சார். மீட்டிங் போனா கிண்ணம் இவ்வளவு கிராம் ரைஸ்ல இவ்வளவு இருக்குன்னு சொல்லிட்டு மேடம் அவ்வளவு எக்ஸ்பிளைன் பண்ணாரு. when we talk that sir, they are their own myths, patients have their own myths, but the facts we only capture. But if we sit and talk, nowadays they are changing, but we need to make them understand that obesity is a disease. So if you wanted to get treated, yes, listen to whatever they say, but it is getting happen. And right now, since medicines are coming up, I feel bariatric surgery also will improve to greater heights, because when right now patients come themselves and ask, sir, I wanted to try Ozempic. He said Ozempic has been launched in India. It has not been launched, but they are able to get that. Okay, it is going to get launched.
They want something which is not
something
available.
to
It is not available.
Yes, sir, it is not available, but not in available, sir. It is out of the North India. There somehow they are selling the same injection which has been not been launched in North India.
Any other questions from audience, sir? Okay, as we approach the conclusion of today's insightful PSG Med Talks, to give away the mementos for the panelists and chief guests, I would like to extend a warm welcome to our esteemed Professor Dr. Prem Kumar S. to give away the mementos. Prem Kumar S. to give away the memento to our chief guest, Dr. Santosh Jacobs. Now I request from Prem sir to give away the memento to Dr. S. Balmurugan. Who is a moderator for this session, consultant bariatric and metabolic surgery. Thank you, sir. I would like to welcome Ramurthy sir from the HOD and Professor of Physical Medicine and Rehabilitation to receive the memento. I would like to welcome Dr. M.D. Varun, Associate Professor and Consultant Pulmonology, to receive the memento. Now I would like to welcome Dr. Tyagarajan Thangavelu, Senior Consultant in Endocrinology and Diabetology, to receive the memento. Now I welcome Dr. V. Kavita, Chief Dietitian and Head Department of Dietetics, to receive the memento. Thank you, sir. Thank you, panelists. Thank you all. As we near the end of this enriching session of PSG Med Talks, it's my privilege to deliver the vote of thanks. As we near the end of this enriching session of PSG Med Talks, it's my privilege to deliver the vote of thanks. First and foremost, I would like to express our sincere gratitude to our distinguished speakers, moderators. A big heartfelt thank you to our wonderful chief guest, Dr. Santosh Jacob, for taking the time to be with us today. Thank you, sir. I would like to extend my heartfelt thanks to distinguished panelists. Special thank you to the organizing team. Lastly, I would like to thank each of you, the attendees, for your active participation. We look forward to seeing you all in future editions of PSG Med Talks. Let's continue to learn, share, and grow together. Wishing you all a wonderful day ahead. Thank you.